So good morning, ladies and gentlemen, dear colleagues. My name is Klára Dombrovská and I work at the University Hospital in Ostrava, and I would like to tell you something about our case report titled When the Body Rebels, and I hope that by the end of this presentation you will understand why we choose this title. Our story began in July last year. We admitted really young woman, only 19 years old, with symptoms such as nausea, vomiting, and weakness. Her only clinical sign on examination was pallor. Her blood pressure and oxygen saturation were within normal limits. However, her laboratory results were really alarming. She had really high levels of urea and creatinine and really low levels of hemoglobin. Due to acute renal failure, we initiated dialysis and we provided a blood transfusion to treat the anemia. The next day, the chaos began. The patient developed acute respiratory distress and she started coughing up blood. So we performed a chest CT scan, which revealed diffuse alveolar hemorrhage, which was later confirmed by bronchoscopy. Here you can see the CT scan showing diffuse alveolar hemorrhage. Her respiratory failure worsened, requiring mechanical ventilation. Even mechanical ventilation was insufficient, so we had to continue with ECMO and continual renal replacement therapy. At this moment, the patient had maximum organ support and we could continue with further diagnostic evaluation. As you can see in this table, autoantibody was negative, Coombs test was negative, Adams 13 activity was normal, and the only findings in bronchoalveolar lavage were rhinoviruses and enteroviruses. Based on clinical course, we suspected systemic vasculitis or lupus erythematodes, so we performed several sessions of plasmapheresis and we initiated corticosteroids and rituximab. After 4 days, in a relatively short period, her respiratory status improved, so we could extubate her, but she was still oligoanuric and dependent on dialysis. So we performed next diagnostic step, a renal biopsy. And what did the renal biopsy reveal? As you can see on these pictures, it was thrombotic microangiopathy. It was a surprise finding, so we had to go to the beginning. Let's revisit the tables I showed you earlier. Please focus on platelets. They were within normal limits on the first day and only mildly decreased on the second day. It's good to remind ourselves that platelet count dropped by 25% from baseline could mean atypic hemolytic syndrome, and the patient had also elevated LDH, low haptoglobin, positive schistocyte, and negative Coombs test, all consisted with microangiopathy hemolytic anemia. So the case was closed as atypic hemolytic syndrome and we started treatment with eculizumab C5 inhibitor. During this therapy, her hematologic parameter completely normalized, but the patient is still dependent on dialysis. And the question is how long should be eculizumab administered? And the question lies in genetic testing, so we did it and we revealed CVH mutation, which means that lifelong therapy is necessary. To conclude, early recognition of atypic hemolytic syndrome is crucial in the critically ill patient with thrombotic microangiopathy. Timely initiation of complement inhibitors can prevent irreversible organ damage, and genetic confirmation supports personalized long-term treatment strategies. Thank you for your attention.
Thank you for saving.
Well, we didn't choose these cases to make the life of hematologists and rheumatologists and nephrologists difficult, but that's how it ended up. Any comments?
Thank you for excellent presentation. I am a hematologist, so I have some comments. So this disorder can progress very rapidly, so very important is quick diagnosis and treatment, and eculizumab is very good option, and I think that it was very good decision. And I have a question. Bone marrow biopsy was done in this patient or not?
One more time. Which
bone marrow biopsy
No.
was done? No.
No.
Okay. So thank you.
Thank you for the nice presentation. You proposed that this patient had diffuse alveolar hemorrhage. Were you therefore surprised that they did not present with hemoptysis?
I'm sorry, I didn't catch the question. Can you repeat it?
Yes, I think you proposed that this
Yes.
patient had diffuse alveolar
Yes.
hemorrhage. Were you surprised that hemoptysis was not a clinical feature, or certainly not one that I think you had on your slides?
Yes, I'm sorry, I didn't mention, but the next day she started coughing up blood.
So should we be doing genetic testing in everybody with microangiopathic hemolytic anemia? The role of genetic testing
Yes.
should be done in everybody?
I think it should be because it defines how long to treat with eculizumab.
Maybe I will ask a question from the position of a person who's seen it maybe twice in my lifetime, last time 15 years ago. How do we establish the diagnosis of HUS today? Are there fixed criteria? How did you arrive? This is the disease, that's why we are using this treatment.
It was definitely because of the results of renal biopsy. We waited for the result for 1 week or maybe more. So it was the last step.
Okay, so the diagnosis is on the basis of pathology, or is there a specific laboratory test as well?
I think we should remind that atypical hemolytic syndrome means that it's thrombocytopenia or a dropped thromboplatelet count by more than 25% from baseline, plus microangiopathic hemolytic anemia, plus acute renal failure.
Okay.
And all together means that she
So
had
it's clinical
atypical
combination
yes,
of those
yes.
findings. Any other questions? Let's go with the next one.
Thank you very much.